Welcome all. This lecture summarises some of the early results from the ANZ Dental Implant Registry. The data has been collected over the course of approximately 7 years, initially starting off as a pilot in 2018-19. Unfortunately, due to COVID, a lot of the activity of the registry stopped for approximately 2 to 3 years, and then activity recommenced in 2022. The data has been captured up until November 2025. My name is Dr. Steven Soukoulis. I'm a periodontist and live and work in Adelaide, South Australia. I've been working with dental implants since 1997, and during my course of work in the implant field, I've noted several issues along the supply chain which I felt required addressing and improvement, namely communication between clinicians when either working with a patient together or as a clinician who ultimately sees a patient at a later date and must have some information and identification of the devices that the patient has to ensure ideal maintenance periods and repair and replacement if required in the future. And also from a clinical perspective, we want to see if we can improve the complication rates for clinicians by knowing which devices are performing the best, which procedures, and which patients may carry certain risk factors which may attenuate or change the treatment plan to ensure that the patient also receives the best treatment and also has an excellent outcome. If we look at the landscape of implantology across Australia and New Zealand, the combined populations of those two countries is in the order of 32.5 million people. There are approximately 28 to 29,000 dentists that service these patients, and there is an estimate in relation to practitioners that perform implantology. That's roughly in the order of approximately 10% in these two countries, and so up to about 3,000 dentists perform regular implant treatment for these patients. In terms of implants that are placed annually, it seems to be over the 400,000 mark. It's quite a large number of devices that are installed in patients year upon year. And there are thousands and thousands of devices that can be utilized to be used in a implant restoration. And you can imagine that if a patient moves between different clinicians, not only in the same location, but out of that in another state or country, that identification of those devices becomes quite challenging. If we look at the demographics of clinicians that provide dental implant treatment, it seems that the lion's share is carried out in a specialist setting. Potentially the most implants placed in the oral maxillofacial setting. Again, with a greater participation rate and more data in the registry than these exact numbers can be elucidated. If we look at medical devices and look at the regulations around those, these devices can only be placed by specialists. Patients are given a patient implant card with information about their device, and that information is also then forwarded on to an independent registry to review the data and performance device, and also carry out benchmarking within devices, procedures, and also clinicians. Currently in Australia, there are definitely over 120 medical device registries. When it comes to endosseous implants, which are dental implants, these must be placed by a dental professional. So it doesn't necessarily need to be a specialist, can be a general dentist. The devices must be on the ARTG, which is the Australian Register of Therapeutic Goods, which is administered by the TGA, and in New Zealand it is MedSafe. However, after this, there is no requirement for patients to be supplied with a patient implant card or any mandates in relation to supplying data to independent registries. One exception to this regulated framework are definitely zygomatic implants, which make up a group of implants that use anchorage of bone well away from the alveolar bone. and in the case of zygomatic implants, they use the zygomatic bone to anchor implants, particularly when patients have lost significant amounts of bone. So they definitely must be placed by a dental professional. Obviously, they're on the ARTG, and the patient must receive a patient implant card as opposed to endosseous implants where it's not required. When speaking to other clinicians, there are several questions about the registry and what is it. Basically, the Dental Implant Registry is a combination of a register where we record information about devices and procedures in patients, and also a registry where we take that data and then analyze it, and then that produces a number of research papers, annual reports, and submissions to the profession and the supply chain. On the registry side of DIR, there is an application that is utilized to enter the data. So this is quite unique in terms of registries. DIR was one of the first registries to utilize clinician-based digital entry of data. And so what we are looking at in terms of capturing information is around the procedures associated with the surgery. So, for example, placement procedures, timing, bone grafts, types of devices, dental implant devices, and then obviously prosthetics, and also the restorative materials that you use with those reconstructions. Once that's finalized, then a registration, which is digital in nature, is created, and then that can then be moved on and communicated over to another clinician or to the patient. And in fact, the patient also can log on to their profile that's created on behalf of the patient by the clinician or the staff, and they can access that information at any time. So this obviously can be helpful within a long period of time, so approximately 10 or 15 years. I have many patients that come to me and don't remember even where their implants were placed, let alone the clinicians that placed them. So this is extremely helpful in the identification of devices, procedures, and patients that present to your practice many years after the event of the original treatment. We then move on to the registry side of the DIR, and the data that's captured is invaluable in allowing us to construct annual reports that can advise the profession of the way that devices are performing, procedures, and some risk factors for patients. They can also allow us to construct reporting systems and dashboards within the application that participating clinicians can review at a moment's notice. And so instead of having staff collate information in an Excel spreadsheet and spend hours and hours, this is an automatic report, and then a clinician can get feedback on their usage and the performance of devices. It also allows us to determine where there may be potential research projects that can help shine light on a particular part of implantology, and then also obviously providing some information back to regulators and also manufacturers in assisting them with product development, and also looking at the performance of some of their products. And finally, when they have to provide data back to the regulators, this can be quite a valuable tool, an efficient tool to collate that information and then send it on to a regulator to support the supply of a product in the market. One of the common questions, and particularly early on in the development of the registry, was both patient and clinician concern over data privacy. This is such an important point because data is collected about individuals. And so within governance of the registry, we definitely adhere to privacy laws, and there is a national guidance on the clinical quality registries that the Dental Implant Registry is following and aspiring to complete all aspects of the requirements from the CQR framework. There's certainly also other layers of the privacy and safety in terms of data that is within the application itself. You can't actually log on and find a patient without having a one-to-one relationship with them, having multiple identifiers. And then even if you do find a patient and then you access their information, it's actually obfuscated, and then you have to request that information from the patient. So there's been quite a lot of thinking around how data is accessed within the application, and then obviously when that data is sitting somewhere else, what is the safety around that? And so we certainly have technical safeguards like encryption of data, obviously physical safeguards, a data center that information is stored in the local jurisdiction. So for example, Australian patients have their data stored in Australia. There are certainly admin safeguards, definitely restricted access. There are only a couple of people within the DIR that have access to the data. And as I mentioned before, we certainly want to replicate what other successful registries have done in terms of their data governance. An important update for the operations of the registry are that patients no longer need to pay for registration of their devices. In the past, patient fees contributed to the operations of the registry, which is extremely helpful, but this is no longer required. The second important update is that we've moved from an opt-in consent process to an opt-out process, and this makes it significantly easier for clinicians to enter patient data, and also easy for patients to withdraw that at a later date. They just need to contact the registry, follow some of the basic instructions that are on the website, and their data is basically removed from the registry at their best. If we look at patient statistics of the registry, we're very closely approaching the 5,000 mark for patients that have been registered in Australia and New Zealand. By the end of the year, we should definitely reach over 10,000 devices, and some of the early data is indicating that there's a slightly greater female representation in the data set than males, and this tends to match in the past what we see with females potentially being more interested in their health and presenting to healthcare professionals at a slightly greater rate than males. Of the devices that are registered, the preponderance is certainly surgical in nature. In fact, 8,247 implants were registered on the registry these last few years. Certainly a greater number compared to prosthetic devices, which sits at approximately 1,370. Given that the registry founders have a strong surgical background, this is no surprise, but we're certainly hoping that the participation rate from the prosthetic side improves over time to ensure that we have a good balance of the data. Looking at age statistics, the average age at time of the procedure ranged between 65 to 69 years of age. The median age at the time of the procedure was 62. The youngest patient to receive a dental implant was 19, and interestingly, the oldest patient was 96. When we look at the proportion of patients in terms of age, 75% or 3 out of 1 patients are above the age of 50, and 25% of those patients in the cohort are under the age of 50. When we look at the total number of devices that patients receive in the DIR cohort, the average device per patient is approximately 1.77. If you're over 50 years of age, that number increases slightly to 1.83. And if you're under 50 years of age, then the number is 1.48 per patient. The distribution of implant usage by tooth location showed that the majority of implants were placed in the maxilla versus the mandible. In fact, 62% of the implants registered on the registry were in the maxilla versus the mandible. There was also an increase in the usage of implants within the molar sites and upper anterior areas for all age groups. Interestingly, when we look at separating patients that are above 50 years of age and those that are under 50 years of age, the frequency of replacement of upper anteriors nearly doubles in younger patients. This may be a function of trauma, as these younger patients probably carry out sports and activities that are high velocity, high risk, and with time, the registry will be able to elucidate the reason for this difference in the frequency. I'm sure it comes as no surprise to clinicians that carry out implant dentistry on a very regular basis that the most commonly used length of implant was 10 millimeters, closely followed by 8 millimeters and then 12 millimeters. In my practice, this is a very common occurrence, and it's nice to see that the data has some parity with clinical practice. When looking at the implant width, again, very commonly utilized diameters shows up in the registry data, with implants between the diameter of 4 to 5 millimeters most commonly registered. The range was 2.75 millimeters being the narrowest implant registered, and the widest implant registered was 9 millimeters. Assessing the number of implants placed by the Clinician-type, the bulk of implants are registered by periodontists. This is followed by OMFS clinicians, which is growing significantly in the last 12 months in the registry, general dentists, and then prosthodontists. Currently, there are approximately 144 participating clinicians, but approximately 44 of those are registering implants on a very regular basis. Assessing the clinician type by type of restoration, the majority of all on-X restorations are carried out by OMFS clinicians. From there, the periodontist place the most number of single implants, multiple implants associated with bridges and overdentures. In the last 12 months, the registry has also recognised that a larger number of extra-alveolar implants are being installed, and hence we are capturing data about zygomatic and other extra-alveolar implants. Given the complexity of these devices, the registry is moving to a sub-registry for these implants to ensure that data that's captured in the registry is relevant for these types of devices. Moving over to the prosthetic devices, looking at the abutment data, there's certainly, again, some parity between implants that are placed in the maxilla and the devices that are prosthetically used to restore these, and definitely more abutments registered in the maxilla than the mandible. If you look at the ratio of implants to abutments, it's approximately 4 to 1. So as previously mentioned, certainly some work to go into increasing those numbers and getting those ratios at a better level to allow for some improved depth of the data and elimination of biases within the data. Moving to the type of prostheses that are registered on the registry, these can be broken up into single fixed crown, multiple implants for partial fixed dentures, i.e. bridges, all on-X reconstructions, overdentures that are unsplintered and those that are splinters. The majority of devices are certainly single crowns at 75% of the devices registered. But interestingly, what has been increasing at the greatest growth rate has been all on-X reconstructions. And although it sits at 5.88% in the registry, in the last 12 months we've seen quite an increase in the number of devices that are registered in this category. I place this slide here to highlight the importance of knowing what prosthetic components are being used to restore a case. Sometimes when patients present with infections, it's actually not patient factors or the implant factor, it's actually the prosthesis that is causing an issue, whether that be lack of seating or some wear of the prosthesis against the implant. Sometimes it can be associated with poor fitting third-party components. And so you can see in this case, placed an implant in a patient in approximately 2016. Approximately 6 years later, she returned and indicated that she had felt a sensation around the implant. You can see clearly on the radiograph there is some marginal bone loss in the order of 3 to 4 millimeters, and that is circumferential. Given my experience in these cases, I regularly remove the prosthesis and examine it and determine whether there is a prosthetic relationship to the infection. And so what we did was we sent the crown back to the manufacturer of the implant and asked the question whether or not it was a genuine component, and the company returned a letter indicating that it wasn't. So the device was not reinstalled, because we can imagine that even if we carried out surgery, cleaned the implant, grafted the implant, and reinstalled the device that was mismatched to the implant, we would then end up with a similar outcome. So what I did, in fact, was install a healing cap from the same implant company, debrided the implant and the lesion thoroughly with PEEK tips and administered antibiotics, and saw her regularly to carry this out on a number of occasions. And you can see in the last radiograph, we literally have complete resolution of the inflammation and infection, and we have had bone now grow over the neck of the implant, which is quite a positive outcome. So this is a non-surgical outcome, and there has been no surgical grafting associated with this case, and now we're moving to restore the site with a genuine component. So from anyone that's involved in implant dentistry, when you receive a referral or you are a patient with an infection, one of the most important things to do is to, one, remove the prosthesis, and one of the safest ways to do that is to identify what was utilized, so using the right drivers and torques to remove these prostheses. So that's the importance of having a registry to facilitate this storing of information that can be accessed by any number of clinicians. As mentioned previously, the DIR captures information about procedures that are associated with a variety of devices, in this case bone grafts associated with implant placement. And so 65% of implants that were registered on the registry received a bone graft. This is an interesting statistic. When I speak to my periodontal colleagues, the number seems like it's low, because a large number of my colleagues, and including myself, carry out a large number of bone grafts with implant placements. And some of my surgery colleagues were indicating that they felt that was slightly high. So again, this is the importance of having a variety of different clinician specialties importing data, so that we can then benchmark ourselves against the other clinicians to have an understanding of whether we are under or over treating patients. On this slide, we can certainly see that a majority of the bone grafting procedures was carried out in molar sites and upper anteriors for younger patients. It's no surprise given the anatomy of these sites, particularly the sinuses for maxillary teeth, and in lower molar sites where we lose quite a lot of horizontal bone on extractions. And in the upper anteriors, as I mentioned before, there is an opportunity that patients are receiving trauma to the alveolus that is accompanied by either mild, moderate, somewhat severe bone loss, and hence the need for grafting. Moving on to complications. Initially, in the formation of the registry, we did not include complication data as per what it would expect, where we separated biologic, technical, and mechanical complications, because it was a bit more information to enter for clinicians. But now, given that we've established the registry, one of the goals is to add quite dedicated sections in the registrations to be able, to allow clinicians to register complications in a much more detailed way. So up until now, what we've done to look at complications is to look at replacement rates. So for example, if you placed a dental implant and then you removed it and placed another one, that was considered a complication. And then for the same thing would occur for prostheses, that if you install an abutment and then replaced it at some time and it was not a temporary abutment, then that was also deemed as a complication. If you look at the rate, we've certainly got a much lower rate than what's been reported in the literature at 0.3%, and so further work is required in this area in the registry, but we're moving towards having quite a detailed data collection workflow for clinicians to utilise. Briefly, what we can see in that graph is that a greater number of complications occurring in molar sites and in upper anteriors. And again, we need to drill down into the data to look at which implants, which bone graft materials, what procedure, and so on. One important aspect of complications is to drill down into the details, and one of the major events that occurs in this data set is that patients receive a bone graft along with dental implants. And so looking at the effect of bone grafting on implant failures is important. And when we look at the complication rates in grafted sites, although a greater number of failures are associated with bone grafts, when we look at the ratios of total implants versus failures and bone grafting versus non-bone grafting, statistically there's no difference between the two groups. So it's nice to see that bone grafting doesn't necessarily affect your outcomes, and indicating that bone grafting has a positive effect versus a negative effect on outcomes for patients. One of the interesting signals that we found while reviewing the data set on replacements was that a large proportion of these were recorded on the day of treatment. And so when we went back to clinicians to ask them about that, many gave an indication that either the implant that was selected was registered and then subsequently not installed in the patient, a second one was installed. And the reasons for that related to either the not achieving primary stability or having issues with fixture mounts and dropping implants on trays or floors. And so this was quite an interesting measure and something that we're definitely going to focus on, because it can give manufacturers some insight into the handling of their implants and how they're achieving primary stability or not, or whether there's a greater rate of dropping a certain implant with a certain fixture mount or delivery system. So we're going to probably drill down a little bit more into the data in the future, and then also come back to modify the application to give us a little bit more robust information on this signal. If we exclude the same day replacements and then look at the data moving forwards from there, we see that the majority of implant failures occurs within the first 12 months, and the majority of those happen within month 4 and 5. One of the things to understand is that operators don't always replace an implant the day that it fails. There's usually a little bit of healing time, so shifting this graph back 2 or 3 months makes a bit of sense. But again, given the data that we've collected, we know that we need to add a couple of features with the application to facilitate the day that the implant failed. It will be extremely interesting to determine that for a variety of different devices and patients. So at the moment, it's important to definitely review your patients within that 4 to 5 month period and determine how they're going in terms of their osseointegration, soft tissue integration. Thank you all for taking the time to listen to this presentation. If anyone is interested in contacting the registry or participating in the registry, we have a QR code there on the screen, or you can just contact us via the email presented there. Thank you for your time. I hope you enjoyed this presentation.